When, with all of this, let's say that our primary care colleagues are great. They're doing everything right. They got the x-ray, not the MRI. They've got physical therapy engaged. They got the right diagnosis. At some point, somebody needs to go to a specialist. What's the trigger? What sends somebody from the primary care setting to the specialist setting?
So I think, as we've discussed, if the diagnosis is osteoarthritis, the patient has exhausted their conservative treatment they've had, they've taken their pills, they've done some disease activity modification, those things aren't working, they have symptoms now, they're having trouble sleeping at night, they're having trouble going to their job, or they have instability or deformity that's really interfering, then it's time to come see us, and we can help them with that.
Okay, now there are various places to go, right? There's orthopedics, there's rheumatology, and there's still primary care. Are there different approaches in each of these specialties? How do they approach the problem?
I don't really think there's different approaches per se. I think there's a relative comfort level for many primary treating physicians, primary care physicians, that is low, quite frankly. They're not comfortable treating osteoarthritis of the knee. I think at the end of the day, if you have somebody who's comfortable with musculoskeletal disease, musculoskeletal illnesses, osteoarthritis of the knee, the menu of options that we've all described are things that are very easy and very helpful for patients, particularly early on in the disease.
So Peter, I want to emphasize that. So if there's an internist or a family practice doctor who feels comfortable with aspirating a swollen knee, then more power to you. But that's what I see in my practice, that many of the internists are uncomfortable with aspirating a knee for whatever reason. So I think if the knee is swollen, patient has pain with every step, patient has night pain or rest pain, that's the type of patient who should be referred to orthopedic surgeon or physician's assistant.
I could see a primary care physician not necessarily worrying about the actual procedure of aspirating a knee, which I think is pretty straightforward. But what do you do with the fluid? Who looks at it? Do you have a lab that's going to make any sense out of that?
So rheumatologists are very comfortable with that.
Okay, so that's the other thing. I mean, you're going to go to a rheumatologist.
If it's purely an aspiration, there are a number of orthopedic surgeons that do joint replacement that don't want to take care of that type of patient that just wants an aspiration. But I think we all are comfortable doing that. And there are others that are more general orthopedic surgeons that have no problem doing that, and we're very comfortable doing that. This is our disease. We're glad to take care of it.
Now, you told me that this was an enormous problem. Was it 60 million people? 20%? Something like that? Order of magnitude?
It was
50 million.
53 million people probably
Close.
now in the U.S.
So with that many folks, it occurs to me that primary care is going to have to get comfortable. There's not enough of you guys, right?
I would think so, and I would hope so as time goes on, that the primary care physicians will be more comfortable with aspirating knees and trying injections if the first-line treatments don't work.
And especially if you can get this down to some sort of algorithm, couldn't you make this the job of a PA or an NP in your practice and really just to say, you're the arthritis person?
So in one of the hospital clinics that I follow, the injections are delegated to a physician's assistant or LPN and they can decide when this patient has reached the end of the line and should go see the surgeon. In my own personal office, I will do my own aspirations and injections. I don't know about you guys.
So in the routine patient, I'll let the NP do the injections. There are some patients that are difficult, the very heavy patients, or someone that has extreme arthritis where getting the needle in the joint sometimes is difficult. But we do biomarker analysis on a lot of our aspirated joints, which isn't going to be done in a routine office setting. So we oftentimes will enroll those patients in research studies. But routinely, it isn't really necessary. Again, unless you're trying to rule out the other diagnoses of gout or Lyme's.
Okay.
Or
so I have to tell you, you may disagree with me, Rich and Andrew, but if I see a new osteoarthritis patient and that knee is swollen, has an effusion, I will tap that knee. It's surprising what you find. Make the diagnosis of gout or calcium pyrophosphate disease, occasionally a hemarthrosis associated with trauma to an arthritic joint. So I will do that the first time I see a new patient. I don't know if you
Well, we're very, this is a little bit off the track, but we think there are phenotypes of arthritis. We think there are osteoarthritis patients that have more inflammatory
agree with
component of their arthritis. There are some osteoarthritis that have a dry joint.
I agree.
Perhaps just the wear and tear type arthritis. So we're very interested in those biomarkers and seeing what kind of profile they have, and we use that to guide our treatment. Many of the treatments we're going to discuss may work in small subsets of patients that we don't characterize well right now, and we think that the biomarker profile will have something to do with that.
Now, you mentioned weight as one patient variable. Are there others in terms
Sure.
of doing this?
I think the very elderly patient, someone with severe cardiac disease, chronic smokers, diabetics, people who are very depressed or on chronic opioids, I think you have to take these other comorbidities into consideration when you're planning treatment, especially if you're considering surgical treatment. Would you guys agree on that?
I would agree, and I think that to your point about patient cohorts, Rich, I think you mentioned metabolic disease earlier. You know, if you look at cardiovascular disease, diabetes, there's a similar pathophysiology that's occurring with low-grade inflammation, oxidative injury, and when that happens in the pancreas, you get insulin resistance and diabetes. When it happens in the muscles, you get other issues going on. When it happens in the joints, you get osteoarthritis. So I think these comorbidities oftentimes come together, and they must absolutely be considered in conjunction with a decision algorithm as to what direction forward we move.
Of course, the final common pathway has got to get buy-in from the patient, right? In other words, you can sit here and discuss pathophysiology all day long, but you've got to have a patient who wants to do X, Y, or Z.
Yes, but I think one of the important points is that the patient does not necessarily direct their treatment. So a patient who has all of these problems and comorbidities, you don't take them to the operating room and say, okay, well, listen, you're just at increased risk, because many of those factors are modifiable risk factors. And we are learning very clearly in orthopedics that BMI, for instance, is a huge risk factor, that diabetes out of control is a huge risk factor. And both from a patient outcome standpoint and from a health economic resource standpoint, you can't take those patients and subject them and the entire system to a high risk of complications. So those are things that you need to certainly get buy-in from the patients, but also a partnership.